Today we are going to discuss about the various procedural errors in endodontics. As you all know, endodontics is we deal with a lot of instruments, machines, a lot of gadgets and all. So endodontics we are going to make a lot of errors while performing endodontics. Okay. So we are discussing under the following headings, that is under definition, classification, and based on the various steps involved in endodontics. Again, the mishaps are classified as access related mishap, instrumentation related, observation related, followed by miscellaneous mishaps. Okay. Under access related, instrumentation related, and observation related, we'll discuss each in detail. And coming to the first one, that is accidents occur during the access preparation. As you all know, one of the most important error, or most commonest of all the types of errors which occur during the access preparation is treatment of wrong tooth. Treatment of wrong tooth is mainly because of the lack of marking. If you do not provide information regarding which tooth to be treated, for example, before going for Repidam application, just mark on the tooth with the help of a marker, or just initiate a small cavity preparation, or initiate access cavity preparation. Then only proceed with Repidam application. So if you do so, you can prevent the treatment of wrong tooth. Okay. So as you all know, treatment of wrong tooth can be so easily prevented. One should make sure that through testing, examining, and radiographically that one has confirmed that the tooth requires the treatment. Which tooth has required the treatment? Open the access cavity before applying the Repidam is one of the main suggested solutions to prevent such error. Second most important common step for us is a missed canal. That is, as you all know that if the access cavity is inadequate, if the access extension is improper, then you may tend to miss the canal. Okay. So additional canals in the mesial root of the maxillary molars, for example, MB2, and the distal roots of the mandibular molars are the most frequently missed. Sometimes there are chances of two distal roots in the mandibular molar. So one may be in the line little far from the mesiobuccal, or a little far from the distal buccal. So the chances of missing the canal can be avoided by proper extension of the access cavity. And another common error which may tend to occur is occurrence of second main canal in the lower incisors and second canals in the lower premolar, as well as the third canal in the upper premolar can also be missed. So one must always be prepared adequate occlusal access to minimize such error. As you can see in the diagram, in the first diagram, improper extension of access cavity may lead to exposure of only the distal canal. Both the mesial canals are not been exposed. Whereas in the second diagram, you can see the second distal canal is not been exposed because of improper inadequate extension. Whereas in the last diagram, you can see the gross destruction of tooth structure because it violated the principle of conservation of tooth structure. Okay. So the F diagram is ideal access cavity operation, and we are supposed to maintain. We have to stick to the objectives of access cavity operation, that is obtaining a straight line access, conservation of tooth, and you have to unroof the pulp chamber. And second important and third important error which may tend to occur during the access cavity operation is the perforation. And the main objective of access cavity operation is to provide an unobstructed or straight line pathway to the apical foramen. So accidents such as excess removal of the tooth structure or perforation may occur during the attempts to locate the canal. The failure to achieve straight line access is often the main etiological factor for other types of intracanal accidents. So perforation must be recognized early to avoid subsequent damage to the periodontal tissues with intracanal instruments as well as irrigants. So perforation, another important commonest error, can be minimized to a certain level with proper, good instrument orientation as well as proper usage of a good radiograph. As you can see in the radiograph, you can see the perforation has occurred. And there is a through and through perforation from the labial to buccal area in the incisor tooth. The failure to change the alignment of the burr could lead to such error. And the second diagram, as you can see, the buccal area has been perforated. That is because the clinicians failed to maintain the distance between the perforation depth. Okay, we have to mark the distance from the corona reference point till the buccal area on the burr with the help of a marker, then penetrate till the floor. If you exceed that penetration depth, you may end up in perforation. The third diagram also shows the clinicians failed to align if the tooth is tilted or rotated, we have to do the adjustments accordingly. If you fail to do the alignment correctly, you might tend to end up in error. And perforations are basically two types: lateral perforation, which is sideways, and focal perforation, that is drilling through the center of the buccal area. And you can prevent to a certain extent the thorough clinical knowledge of the tooth morphology and the outlines of access cavity preparation. And you have to identify the tooth angulation according to the adjacent teeth and proper reading of the preoperative diagnostic radiograph to get information about the size and extent of the pulp chamber and internal changes, the calcification or resorption. Whenever whenever there is if there is no obstruction in the pulp chamber, you can you can feel the blood drop. Whenever you penetrate and you reach the pulp chamber, you can feel the blood drop. But when the pulp chamber is fully calcified, or when the calcific masses are present in the pulp chamber, you may not get a blood drop. So in the case of the marking the marker on the burr, the length of penetration is very important. Okay. And the law of color change says that the floor of the pulp chamber is always darker. When the floor is not found darker, then it could be because of the presence of calcific masses. Can be confirmed with the radiograph. A good radiograph will help to confirm the presence of calcification in the pulp chamber. And you can always take a radiograph or RBG from different angulations to confirm. Okay. The orientation of the alignment of the tooth. So in the diagram, it is clearly shown the burr is held along the radiograph to estimate the depth of the penetration. And operator procedures access without rubber dam or using split technique is preferred in specific cases. So use of fiber optic light magnifies and removal restorations when possible. For example, if we use a rubber dam only on a particular tooth to be treated, then you may tend to miss the alignment of the tooth. Okay, suppose instead of that, if you use a split technique that is along with the main tooth to be treated, the adjacent tooth are also involved along with the rubber dam. In such conditions, you can easily judge the alignment of the tooth, and you can use the fiber optic light and magnifies for a better view, and also all the removal of the restorations when possible, so that all the restoration may interfere with the vision. And if you come across a perforation, how can you recognize patient may complain of sudden pain? There will be immediate or sudden hemorrhage can be present within the pulp chamber, and with a good radiograph, we can easily recognize the perforation defect. An apex locator gives an important clue. And when you irrigate, you can feel a taste of irrigant in the mouth. That is all indications of perforation. And the next, once the perforation has already been occurred, how good you can treat it. So basically, lateral perforations basically divided into, based on the position, it is again divided into above the crystal level or below the crystal level. When the restoration of the perforation is above the crystal level, it is easy to treat because better visibility, and we can easily treat with the help of a material which can seal the defect, preferably MTA. But if the defect is below the crystal bone, you have to get the defect above the crystal bone, either by orthodontic extrusion or by surgical crown lengthening procedure. Once the defect is, once you get the defect above the crystal bone, the better visibility, and you can easily repair it. So the perforation below the height of the crystal bone in a coronal third of the root, the treatment goal is to position the apical portion of the defect above the crystal bone by either orthodontic extrusion or by clinical crown lengthening procedure. And then once a restoration defect is above the crystal bone, you can easily repair with the help of a most successfully used restorative material so far, that is MTA. So MTA has a biomimic property. It can induce osteoid formation. It has a lot of advantages, but only disadvantage in MTA, its setting time is around within 3 hours. It takes around 2.45 minutes to 2 hours 45 minutes to set. So we have to maintain. We have to seal the restorative material with the help of either glass aluminum cement or any other restorative material immediately after placement, because it takes a long time to set. And another type of perforation is furcal perforation, as we already discussed earlier. The furcal perforation is nothing but we are cutting through the furcal area of the tooth, and immediate sealing using the suitable restorative material can be done because which is inside the pulp chamber. So the limiting the restorative material or reparative material is very easy when compared to the lateral root perforation. Okay. So basically, the non-surgical treatment management is main the protocol on the step-by-step protocol is that the site of the perforation must be found first. The floor of the perforation should be cleansed. The bleeding has to be stopped either with the help of a stiffened, or you can compress with a cotton ballet and you can keep it for some time. And then MTA has to be manipulated and has to be applied to the perforation. And MTA takes around more than 3 hours to set. It should be covered with the fast setting cement, like preferably GAC. And other canal orifices should be protected by placing paper points or instrument in the canals to prevent blockage. So suppose you are repairing a buccal defect, and we have to make sure that all the other patent canals should be blocked by a paper point or by cotton pellet. Then proceed with the perforation repair. Then establish the patency. Otherwise, you may cause problem with the packing of metaparts, packing of MTA inside the canal, and an MTA sets, it becomes very difficult to retrieve the MTA. And the surgical treatment modality is nothing but it requires around more complex restorative procedures, and it's more demanding oral hygiene from the patient. So patient compliance is at most important when surgical treatment is considered. Surgical alternatives such as hemisection, bicuspidization, root amputation, and intentional implantation are also preferred. Surgical hemisection means a single tooth has been split into two, and you can treat it as a two different tooth. For example, molar is split into two, and you can treat it as two premolars. That's hemisection. And bicuspidization, root amputation, splitting on this entire part of the root has been amputated and removed. Intentional implantation, if the defect cannot be repaired within the oral cavity, we can repair it outside. Post extraction, repair it, and then reimplant it. That is called intentional implantation. So whenever the defect is inaccessible, whenever there are multiple problems exist, such as perforation combined with separate instrument, and whenever the prognosis is with other surgical procedures is very poor, we proceed always with the surgical mode of treatment protocol. So that covers the topic of accidents occurred during the access cavity operation. Okay, so we'll stop here. We'll continue in the next section.